Well, thank you for the invitation today. It's always uh, nice to speak to you. I think I spoke last year as well. Thanks for accommodating my schedule because this afternoon I'm flying to Portland for the Society of Forensic Toxicologists meeting, and so we'll see what's going on out there. We probably have a little bit of I don't know, National Guard or whatever's out there, but it should be interesting. So I'm going to give you a little bit of an update. We're going to go fairly quickly, and hopefully it will be of value to you. I'm going to review fentanyl because everybody's always concerned about fentanyl because methamphetamine is kind of making a comeback, and I'll kind of show you where that link shows up with fentanyl, and I'll do a little bit of Delta 8, Delta 9, and volunteer studies, uh, oral fluid update, new drugs to watch for. Now, let me start with fentanyl. It is obviously added to a lot of street drugs, and we'll get into that in a moment. And it's just like everywhere you want to go, it's present. So it's in your neighborhood. You'd have it, anybody deliver it to you. But we are seeing the disappearance of the analogs, although there seems to have heard of reports of carfentanil being found again. I think that was up in the Northwest, the Seattle area, if I'm not too mistaken, which makes that extremely dangerous. But as with all chemicals, you start with a base, and that's 4-AMPP, and that's been the hotbed of importing of that, and then actually having more and more precursors to that to manufacture. Now, fentanyl was causing primarily 110,000 deaths in 23. So I put it between diabetes and kidney disease for fatalities. But in 24, it did drop. So, if 80,000 deaths is a win, we'll take it. But we continue to see a little bit of a drop in that. Now, opium was the precursor to fentanyl. And nobody needs to work that hard to make a narcotic. And we'll talk a little bit more about a new one that's kind of made its way, so you don't have to grow your opium. But the fentanyl seizures have increased. The first seizure was way back in 2014, which is basically over 10, 11 years ago. But 23 pounds of fentanyl is still a massive amount of drug. Average seizure, at least recently, was only around 2.6 pounds. It seems now, based on what we're seeing on television with the speedboats and that, there seems to be a lot of drugs coming on the big speedboats, and I'm sure much of that is fentanyl, perhaps a little bit of cocaine, and even methamphetamine. So there are a lot of pills being found, a lot of powder. I think yesterday or the day before, they arrested people in Kansas City in a temporary housing with 9 pounds of fentanyl. And of course, that's supposed to be about 3 million overdose deaths, which would wipe out the entire state of Kansas. But some of this is being introduced with other drugs, and we'll get into that just a minute. Now, I'm trying to making this interesting for some industry groups, and I copy the slide over for you all. There was the Ozark TV series, and it started in 2017. Jason Bateman was a money launderer, and they went into southern Missouri in the Ozark region, where there was a farmer growing poppy seeds. And back in 2018, in that episode, again, fentanyl was being introduced as a co-drug to enhance potency with heroin. And we think of, when you think back, this is a couple years before COVID. So this is continues to be a problem for more years than we remember. Fentanyl positivity rates. I'm going to have two charts here for you. They're very similar. We'll just kind of hit this one for urine. We've been testing fentanyl for a number of years. But the big category, the big blue at the bottom, is the random rate. That's where we find most of our positives. And it's not pre-employment. You kind of think of pre-employment as the people that are less sophisticated, perhaps. And remember, this is all non-regulated. We extracted out the probation, parole, rehab types of people. So this is our collections. So this is the working population that we would be hiring. So pre-employment is actually quite low. It's at 5% of the positives have that as an issue. There's some return to duty, some post-accident, but by far random is, and two reasons probably. One, in pre-employment, you know you're going to be tested, so obviously you lay off drugs for a few days if you're using. I think the other part is the substitution of synthetic urine is epidemic in the urine drug testing program. Now, this one is oral fluids, and again, at the bottom, the random is primarily where we are finding our positives. Pre-employment's still around 4%. Reasonable cause, post-accident, it's still there. So I don't believe that these are hospital administrations of fentanyl because we usually don't see those samples. If they are so severely injured, they are typically not what we see. Now, this is the positivity rate for fentanyls that we're seeing. Purple is urine. Blue is oral fluid. We saw a dramatic rise all the way into 23 to early 24. We start seeing a reduction as we get into Q4 of 24. And then Q1 of 2025, we have a further reduction. But what I don't have this chart updated. I didn't get the data in time when we submitted this, but we're starting to see a rise in fentanyl again. I mean, we're seeing urine somewhere around 1% of the total of positivity. We are seeing, because of the rate of increase of fentanyl usage, more of our clients are selecting to select fentanyl, and that may be one of the reasons why we're seeing an increase. Fentanyl, I think this is old news probably for most people. July, HHS added fentanyl to their federal panel, so that would be federal employees, but not DOT. Now, DOT is out there with their NPRM and trying to determine what they're doing going forward. I think all those comments are in. I think the vast majority of the public in their comments are supporting fentanyl to be added. Fentanyl plus norfentanyl will be added in urine at 1 nanograms per mil. DOT is also proposing to change their morphine to 4,000 nanograms per mil to be in compliance or in lockstep with HHS. Now, the one thing that is different, if we talk just a second about oral fluids and fentanyl, they're only going to report fentanyl parent in oral fluids and not both. So when I talked with the people at ONDCP, the plan was to go live in January of 26. I don't know if that's still going to happen based on comments where the government is right now with its policies, but the laboratories are ready. The laboratories have been doing proficiency testing for months now. So the laboratories are not going to be the holdup. It's just going to be administrative planning. here's a we're on our fourth wave of fentanyl, and I think going from the left to right. Wave number one, it was the prescription opiates, the hydros, the oxys that took over the United States for quite a few years. As those drugs became controlled in a better distribution manner, heroin became popular. I mean, it needed something to replace your narcotic. Uh, then it became fentanyl because fentanyl was so easy to manufacture, it's easy to transport. You can make it anywhere when you want. But then they started adding fentanyl to other drugs, primarily stimulants. We do not see much in the way of fentanyl being added to narcotics. This is our positivity rate in urine. It's very similar to oral fluids, so we're only going to show this once. But obviously, if you're into the fentanyl and the poly drug use, marijuana is always very popular. It's always there. But when we go down the list, we're seeing 20% of them are methamphetamine, or 19.9. We see a high amount of co-joint with methadone, and it's believed that they're supplementing fentanyl or some other drug with fentanyl, and they're coming up with these methadone positives. At first, I thought this was probably a mistake in collecting data, but the oral fluids are the same way. Cocaine, there's another stimulant at 8%. So when we get down to morphine, it's relatively low at 5%. Benzodiazepines, because everybody wanted their Xanax, from the street, and ended up with fentanyl. Now, because methamphetamine is so popular or present with fentanyl, I thought I'd give you a little bit of history on methamphetamine because I have a pharmacy background. I came out of Utah after working for 18 years, 16 years. I've been here 19 years. But methamphetamine was hot back there in Utah. It was very popular there. There was another hot spot, which is actually Missouri. For instance, there was in the Ozark area, which is the recreational, it's a wonderful place recreationally. But in the 80s, there was an individual that started with methamphetamine and just grew his industry out of the Ozark area. And of course, it flowed in all directions. Independence, Missouri, it's the home of Harry Truman, got the nickname of meth dependence instead of independence, and it is still known as that locally, even after 20 years, and methamphetamine is still a problem. So when I was in Utah, I was with Northwest Toxicology there, and we did analysis for house cleanups where there would be a rental property or a home that was turned into a meth manufacturing facility. And we were doing these alcohol swabs, or they were provided to us because you need full PPE going into these places. And we were measuring alcohol swabs for the presence of methamphetamine. And of course, the drug soaked into almost everything. The kitchen had to be basically destroyed. The flooring, the carpeting, the subflooring, all of that absorbed all of this stuff. So most of that was iodine, the acids, the phosphorus, and we'll get into how this was going on. So obviously, it's difficult to dump those chemicals. So they basically opened the back door and threw it out. So then you had a toxic landfill because the soil had to be excavated through the backyard, about 2 to 3 feet. So is that right? Okay. So methamphetamine, is actually making a big comeback, and it doesn't really show up in my workplace population yet, but it certainly shows up in my probation parole. It's like 50% of the people are positive for methamphetamine. Uh, the confiscation, even overseas in East Asia, 236 tons of methamphetamine. And there is we'll get into that in a second, with Japan is kind of the leader of methamphetamine. So we have the pills, we have the powder, we have the crystal meth, we have the precursors being identified. It is just coming to be quite a problem. Now, we have methamphetamine mixed with fentanyl. We all are aware with xylazine mixed with fentanyl to enhance all of this. But one of the biggest dilution powders that is used is acetaminophen, which is quite unexpected. But it's pretty easy to get acetaminophen, and I guess you can just pop the capsules and pour it out, dilute it up, and away you go. In the United States, it seems that the methamphetamine is far more popular through the central part, and these are from the summer. St. Paul, Minnesota, with 900 pounds of tablets. Houston had the crystal meth. So a lot of this is just easily produced. You could get your own pill press. You could get pill presses easily through Amazon. I think they're finally starting to control that, but you can create in your garage thousands of pills per hour if you would have that intention. Now, we're going to talk a little bit about the history, where this came from. Methamphetamine was actually created by the Japanese scientists in 1919. And I'm not sure how many of you track some of this, but one of the methods was called the Nazi method because the Nazi Germany used it as their method. So they were using red phosphorus, which was basically the flame for matches. And you do iodine, you reduce the ephedrine, you make methamphetamine. So they made it preventing. But during World War II, beginning of the war, this drug became very popular because Germany decided, as they marched through Europe, that they were just going to fly through Europe, just through Poland or whatever country they were going, nonstop. I mean, so this is where this drug became popular. They became superhuman, if you will. But they were placing the methamphetamine into chocolate for the pilots. It was Flyers chocolate. Tank commanders had Tankers chocolate. But they were giving it to the soldiers, as the ground troops as well, to combat fatigue. By 1941, the Allies were kind of forced into having to counter this and actually added amphetamine as well in tablet and inhalant form. And now you can see it off in the corner, the Benzedrine inhalers, and it eventually became illegal. Well, I shouldn't say illegal. Became restricted. It went into schedule status because when I was working as a pharmacist in 1970, people kept asking for Benzedrine. They were still looking for the amphetamine inhalers. So the military is still kind of using this. Modafinil is used for shift work, for people going from nights to days, to help for alertness. I would imagine as the B-2 bombers went over to Iraq, they were probably given modafinil for alertness. You can only drink so much coffee in a tiny airplane cockpit. So they're going to use the stimulants. They were typically called go pills. The no-go pills after you're back is typically something like Ambien. Now, in the United States, Benzodrine was the inhaler. The scheduled drug classification started in 1970, so kind of went away. It got removed from OTC back into the pharmacy, but the inhalers went away forever. 1980s proliferation of home labs. That's where the beginnings of methamphetamine began. Growing up, the kind of where I grew up in North Dakota, is probably as far away from drug issues as you can get. But everybody knew about Hell's Angels because they had methamphetamine, they were narcotics. And so that was one of the early groups. And we'll have a picture of some of this in a moment. In 2005, limits were placed on ephedrine and pseudoephedrine. To ultimately the tablets went behind the pharmacy counter, because as I remember, you used to buy bottles of 100 Sudafed at 30 milligrams each. In order to kind of control it, they went to blister packaging, but obviously that wasn't successful. So that's why we signed for it to get it. Phenylephrine became the substitute, which was not a very good a substitute, but now we have some of the others like Afrin, Zyrtec, Allegra, Claritin for allergies. So for back in the 60s into the early 70s, White crosses were known as trucker speed. You could buy those in every gas station that were available. And so they could actually drive from LA to the East Coast without sleeping. So that kind of led to the logbooks for DOT, because you could only, 10 hours of continuous driving. That led to some of all these things. So truckers then went to tons of pseudoephedrine, ephedrine to get the equivalent high. So prescription-wise, methamphetamine is known as Black Beauties. Biphetamine, with the physician group, if anybody remembers that, was the first Adderall. And again, it was used for weight control way back then. Now, methamphetamine, we're almost done with meth, and we'll get into marijuana. But one of the things that for every pound of meth, there's 6 pounds of toxic waste. And we have Breaking Bad, the TV series, is still on Netflix. We have Jesse Pinkman and Walter White were the two people that made the perfect methamphetamine. The blue smoke coming out of his mobile van, again, moving around because there are fumes and things that need to be destroyed. So it is kind of a very interesting series as it relates to all the trouble that comes in drug distribution. So we have the blue meth. Meth is never blue, but it is television. And what we saw in the background on the other side is piles of money that were being generated in cartons and cartons of methamphetamine. But he was a chemistry teacher trying to make money for his family with a diagnosis of lung cancer. Now, leaving meth alone, we're done with that. We're going to talk briefly about marijuana. So CBD was the originating compound for these marijuana alternatives. So I think for those involved in drug testing, everyone knows it's delta-9 THC, or tetrahydrocannabinol. But with the advent of CBD being very popular, they turned CBD into delta-8 and delta-9, and delta-8 is not specifically mentioned as a prohibited drug, so it became legal weed. Okay. But through all this time, in the last 5-6 years, there's various strains of marijuana being created that have more delta-8, because delta-8 was almost non-existent way back in the 70s and 80s, and so it was never considered to be a drug of importance or a metabolite of importance, but it certainly is now. So I've been involved with research for a while, for a number of years, with we'll show some data that was publicized probably 12 months ago. It was at the SOF meeting in St. Louis, and we'll kind of go into this because it deals with a little bit of impairment, the early studies on impairment. We'll get into that in a second. Here's the other ones besides Delta 8. There's Delta 10, there's HHC, THCP. By modifying that molecular structure, kind of think of it as a Lego add-on. So you put a little yellow one here and a white one there, blue one, you make different compounds. Some of these are illegal in some states, but not all states. For instance, Kansas still does not allow any Delta 9 to be sold for recreational or medical. However, you can buy all of these. Plus Delta 8, you can buy Kratom, you can buy anything that you want. So Texas eliminated Delta 8 from being sold to protect the Delta 9 industry. So there are things going on here that even if we move marijuana from a Schedule 1 to maybe a Schedule 3, there's some discussion of maybe making a Schedule 2, it still becomes a very complex issue. The only reason to deschedule or put it into a Schedule 2, 3 is it now allows these shop owners to do banking, because Schedule 1 you can't bank, and number 2, you can start to deduct business expenses. So that's why the marijuana industry is pushing so hard to get it into a schedule. Now, we have some things going on with nomenclature that I thought you should be aware of, and this is the only slide like this. But we start with CBGA. That's the mother chemical. Then we make tetrahydrocannabinolic acid, and this is where the confusion has started, because the manufacturers of this and the plant people have abbreviated this THCA, which has been typically the abbreviation used by the drug testing industry. Okay, so we go through, enzymatically, we decarboxylate it, get rid of this. We now make THC, and we do a little hydroxylation through the liver. We make 11-hydroxy, and then down below here we have our carboxy metabolite that we look for in urine. Now, going back, this is now going to be called Delta 9 THC. We can either use a delta symbol or we can spell it out. But in transferring data through all of these portals to MROs, the delta symbol can really mess you up. So we are spelling it out as delta rather than the symbol. Now, this drug here, 11-hydroxy, is also psychoactive. We have certain states in the U.S., probably the most famous ones right now are probably California and Washington, that ban the reporting or testing for this inactive metabolite, because this is going to be conjugated. It's going to be a glucuronide out here. This drug here, 11-hydroxy, is found in urine, and so is THC, which is got papers on this published. This is about 1/3 as by weight or by amount as the carboxy. So at some point in the future, as we get closer to impairment and recency of use, perhaps 11-hydroxy will become more popular as an alternative, because right now we're going from looking at carboxylated urine in California and Washington State for their industries that are restricting to oral fluids because they're looking for THC parent. Just a little bit on the structures. Here's an open ring structure for CBD. You can do some acid reflux with that. You can close it. You get a delta 8 with this double bond. Delta 9 is over here. Delta 10 is here. And then we talked about extra potency. You add 2 carbons on this aliphatic side chain, and you make it 30 times more potent. So there are things that can be done that are easy. You put an acetate here, it becomes even super potent again. You replace that hydroxyl. So there are things that the scientists are doing. They're basically going through the literature, finding every possibility of things that you can change. And then there's different isomers of all of this. It's very, very complex. Get into a little bit of impairment here with the studies. Dr. Vandry, Tori Spindle have been spending a lot of time on this for years. Their cannabis science laboratory. I have a lot of respect for them, and Ed Cohn's been involved in marijuana at NIH forever. The things that I wanted to point out, we're going to go through these fairly quickly. We have oral. We have delta 8 with these lower ones here. These are different doses, 10, 20, and 40. And this top line is 20 milligrams of delta 9. So this is kind of that relationship. So if we are doing oral dosing, this would be gummies or whatever. It takes about 2 hours to 3 hours to kind of reach that maximum subjective effect. This is different when you do vapes. I mean, obviously, vapes are going to happen in 15 seconds, and then it still trails down. But with the oral, it's important to remember that you aren't getting back. This is a subjective scale of how do you feel, right? 1 to 10 type of thing. So these are all elevated even at 4 hours with the lower doses. So there is impairment going on. Now, this is a slightly different slide demonstrating this is about driving. So if you have confidence to drive, again, down here in this 2.5 hour timeline, people do not feel confident about their ability to drive, whether it's oral. It's actually sooner with vaporized. So keep that in mind, the timing there, because there's next study that was done was by the AAA Foundation for Traffic Safety, reported in March of 25. So they've interviewed 2,000 users, and 84% drive the same day they consume. 53% drive within an hour, and you saw the impairment that was by people in a study controlled environment. These are people on the street. 44% consume multiple times per day, and then 46% it doesn't have little or no effect on driving, which is entirely different than this group here. This is a laboratory setting. Everybody feels that their ability to drive is impaired, and even with oral, it goes out probably 6 hours, up to 8 till you get back to normal. So this is a longer lasting effect in a controlled setting than people that are actively using. So I guess this is where at some place we need to develop a per se level rather than trying to figure this out. So this is where the breathalyzer with alcohol, it tells you if you're impaired. You don't have to judge that because people obviously are driving while intoxicated as they leave for the bar at night. This is a little bit of different data that's not been put into print yet. We have been, last 2.5 years, we've been collecting the Delta 8 concentrations on every Delta 9 screen positive. So we used to have about a 99.9% confirmation rate. Every time a marijuana sample was screen positive, you always got a Delta 9, 15 nanograms or greater. Well, out of these 373,000 samples, 62,000, I think that's around 17%, had Delta 8 concentrations and no Delta 9. So they are using a lot of Delta 8. Now, out of that group, there's still almost 20,000 samples that are both Delta 8 and Delta 9 negative, which means it's one of those other designer. It could be an HHC, it could be a Delta 10, those types of compounds. The acid proton inhibitors, they're rare. I mean, those are not causing this problem. And we are seeing levels that are very high. For those not involved in drug testing, the typical concentration cutoff to determine positive versus negative is 15 nanograms. So we see a lot of high samples for Delta 8 in the thousands of nanograms, which tells me that they are vaping throughout the day. So it is not a single use. Nobody's getting this much from a single use. Now, this chart on the right compares 3 years. And so we kind of looked at the Delta 8 concentrations. So it really has not changed much with the amount of Delta 8 usage. And it's similar in all of these different categories, post-accident, random, pre-employment. So it seems to be stable. That's about what I get out of this display, that it's not more, it's not growing anymore, but it is certainly present. Now, we're going to finish up here quickly. 7-hydroxy and metrogeny, or 7-hydroxymetrogeny, because 7-hydroxy is the metabolite. And it was an interesting day here yesterday because U.S. Senator Marshall came, Roger Marshall, came to the laboratory to get our impressions on kratom. Now, kratom and 7-hydroxy are related. Let me explain how this goes, because there is a request to control all of this. Now, kratom is an extracted plant product. It's a leaf out of Metrogenaceae speciosa from Southeast Asia. So it's growing. People are drying the leaves. They're grinding it up, turning into a powder so that it can be consumed in a capsule or as a tea type of thing. In low doses, it has some stimulant activity, and in high doses, it's good for pain. Now, so there is the metrogeny, the original kratom, is being replaced because 7-hydroxy isn't the active metabolite. 7-hydroxy is 10 to 100 times more potent than morphine. So they are synthetically making this and selling it in most states as tablets, vapes, liquids. You just go to the gas station, convenience stores, grocery stores, anywhere you go, you can find kratom, at least in this town. I can buy it 2 blocks from here. So the 7-hydroxy is the one that everyone's concerned about. And it's about 10, 15 years ago, the Congress tried to ban kratom, the leafy the vegetable version. There was so much pushback that they dropped it. Now, HH Secretary Kennedy proposed this back in July to the DEA to get this regulated, and Senator Marshall is going to push this some more because of the severe addiction that's coming with the 7-hydroxy. The 7-hydroxy is not a traditional opiate structure. It is its own unique, but it does bind to the mu receptors very well, and it can kind of be overcome with Narcan. Now, in August, we took 1,000 random people from the submitted urine samples to the lab, which is not hard for us to come by. We do 20,000 a day. So we took 1,000, just pulled them off after they've been tested for the normal drugs. We use that urine to go looking for kratom or metrogenine and 7-hydroxymetrogenine. We found 1%, 1.09% positive rate. Now, for those that are not aware, that's more than our oxys and our hydros and our codeines together as a positivity rate. So it is widely used. The 7-hydroxy is made by American Shaman, largely for American Shaman, which is located in Kansas City. So after they've had the publicity on television in the last 24 hours, I'm sure that they're going to go get a visit by somebody to try and shut them down. So it is the next replacement for fentanyl. So if you can't get fentanyl and you have an opiate addiction, this is the way to go. I mean, people are using it for alcohol. They're doing it for opiate addiction. It is the replacement addiction for alcohol and the traditional narcotics. So something for everyone to watch out for. Hopefully we can get ahead of this one before we go further. Now, trying to get to the end of this, there's probably nothing that's going to replace fentanyl. It's still the number one drug. There's purple fentanyl. It's mixed with lidocaine, mixed with you have methamphetamine and other stimulants. The one drug that was popular a couple of years ago, and I'm not sure if that version's going to make it to the United States. There was Captagon. It was being manufactured and sold through Assad of Syria. There was millions of tablets to became their chemical courage. So basically, it is just a amphetamine and theophylline linked together into the one compound phenethylene, and when it's metabolized, I get theophylline metabolites and I get amphetamine back. So perhaps it could be in use somewhere, but not everything is Adderall. We hear about pink cocaine. It's really not cocaine. You have the MDMA, ketamine, mescaline stimulants. We have the nitazines, which are another class of drugs. There's, I think, 6 or more of these. I think only a couple have been put into emergency scheduling. That's what we're trying to do with 7-hydroxymetrogenine. So we have all of these very powerful drugs. Now, the one at the bottom, Tramadol, is probably nothing that we need to be concerned about because it was pulled off the market in India. But for those that are prescribing tapentadol and carisprotol at the same time, that's probably not a very good choice, and probably need to change that because those two drugs together have been found to be highly addictive. So we will have them as separate drugs, but together highly addictive. This is a little bit of positivity rates. Our federal level here is around 2.2, 2.3 year after year. We've kind of gone from the high of 10 from the beginning, but some drugs increase, some drugs don't. If we add them together, the general workforce is somewhere around 5%. These are your non-regulated, but when you throw them all together, you get, the general workforce is 7.6. So combined, it's at 5. So these numbers are significant because we're looking at about 5 million samples per year. Oral fluid rates are right below it. we're around 8.8% positivity rate. Again, that's probably due that people are not substituting their urine, and that difference is probably those people that we're finding that have not cheated on their drug test. Positivity rates based by reason, and we're almost there to the end. Um, this is general workforce urine. Reasonable cause, it's 29%. The post-accident, pre-employment, we could easily see it's always kind of stable. We haven't had a big impact. Post-accident is 11%, 11, 12%. Even return to duty, we're still finding 9, 10% after all these years. On the other chart, it is oral fluids. For cause, we're doing oral fluids. This is 42. Wait a minute. Is it 42%, 29% with urine? So part of that, I'm not sure why that would be the case, except we can find these drugs quicker. Random, we're again, some of these numbers are somewhat equivalent, but our combined workforce is at 8.8%, which is more than our urine. So, as a quick summary, the fentanyl deaths are down. 80,000 still way too many. Fentanyl will be added to DOT. Hopefully, they'll probably. The goal is to approve it by January. I don't know if there's going to be delay in implementation. If you have a DOT account, it's just going to be automatically added. People ask all the time, how much is that going to add to the overall cost? It's probably for most people, probably be at least $1, maybe up to $3 to add to the panel, largely because the reagent's so expensive, and there's only one vendor. So the designer marijuana, there's definite impairment with all of this. There really is no safe way to go. And, 7-hydroxymetragenine is just going to continue to be a problem for the foreseeable future until we get our control on that. But the plant, the ground up leaf, will probably still be available. Federal oral fluids, there's actually 11 reagents. There's only 4 approved, and it has to be FDA approved. We're looking probably all the way through 2026 yet for the FDA to get through all of this approval. Certainly being out of work for a month or, idled certainly hasn't helped that process. So hopefully the oral fluids do get approved. The laboratories are reluctant to jump in and get their laboratories accredited because even if you're accredited, you can't test because you need FDA-approved reagents in the United States. So hopefully FDA will reconsider some of these restrictions and it all gets a little bit better. So thank you for your time. Hopefully I didn't go too extra long. If there's any questions and if I can understand you, I'd be happy to answer them.
Morning. I'm wondering, what are your thoughts on the MAPS program that's using Suboxone and on Subutex for fentanyl use? And do you?
I don't know the answer to that with Suboxone. So I would have to pass. It's more of a clinical question that I am not well versed on, so I apologize for my ignorance on that question.
You mentioned, first of all, thank you very much for the useful lecture. You mentioned about delta 8 and a little bit about delta 10, and at one point the fire was going up. They say that it's increased the production of delta 10. Is there anything about delta 10 that you'd like?
I'm sorry. I'm having a very hard time. It keeps breaking up about every word. So can we try the question again, please?
I'm asking about delta 10 versus the other delta 9 and delta 8. So
Okay.
is there any plan to test for it, or?
Not sure I understood your question still, but I think you asked about delta 8 and delta 10. Is that correct?
Delta 10.
The delta 8 and 10 are probably 50 to 75% as potent as delta 9. So, delta 9's kind of as the starting point, either more or less potent. I think delta 10 has become quite popular. I'm not testing for it currently. HHC is been very popular in Europe and became one of their designer cannabinoids of choice. But I'm not sure if I understand the rest of your question with the acoustics that we have.
Thank you for the very interesting lecture. I had a question in regards to the 0.3% cutoff. Is there a way to distinguish between somebody taking a gummy or some kind of product that's sold over the counter versus a person that has a medical marijuana prescription? I know we've run into this problem, and sometimes we reach out to the psychiatrist, and there is the 8 or the 9 variant. The delta 8 or the 9 variants, and it's hard to know who's taking what, and is there a way to tell who's taking an over-the-counter sold product or gummies or edibles versus marijuana?
We've with the studies that we've been involved with, there are those kinds of things. There's a full spectrum oil, hemp oil, which has basically it's a crude extract and throw it into a tincture people take versus solid dosage forms versus vaping. The one thing that we used to count on was THCV from an MRO point of view. The V would be the bivarin, which would be the 3-carbon chain, and you would say if you found that, it meant that you ingested the plant material versus marinol, which was synthetically produced with a 5-carbon. It's a little confusing now, to say the least, because we are seeing with the gummies, we are seeing THCV in oral fluids. We're seeing it in blood. We're seeing it in the urine. And in theory, most of these are all synthetic, but we are finding it. So I guess if you don't find it at all, you probably have more of a marinol type of sample that you're looking at. But really the marinol question, dronabinol, has fallen off. There's hardly any request for that anymore because everybody can get a medical marijuana card in most of these states. And so they kind of use that, I think, as their alternative. And, whether it is a gummy, depending on your age group, you're not smoking or whatever, there is basically no good way to determine what you've ingested anymore. And that's unfortunate. Well, if there's no more questions, thank you for. Or was there another question?
I don't know if that makes sense, but okay, that.
Well, if there's no more questions, I thank you for the opportunity to speak today. Hopefully, you learned just a little bit more than you did coming into this group. It's a very prestigious group that I'm speaking to, so thank you very much.